Okay, the final item of business this evening is a members' business debate on motion 18369 in the name of Kenneth Gibson on recognising the impact of chronic kidney disease. This debate will be concluded without any questions being put. I'd encourage members wishing to participate to press the request to speak buttons, and I invite Kenneth Gibson to open the debate around 7 minutes. Mr Gibson.
Thank you, Presiding Officer, and thanks also to each member who signed my motion and to Kidney Care UK, the National Kidney Federation and Kidney Research UK for their briefings to members for today's debate. I warmly welcome them to the public gallery along with representatives of the Scottish Kidney Federation. Presiding Officer, our kidneys are our body's silent workhorses. They filter our blood to remove waste, excess fluids and toxins while regulating blood pressure, balancing electrolytes, producing hormones for red blood cell formation and activating vitamin D to strengthen our bones. Yet our kidneys seldom receive the same recognition as other organs. This is despite the fact that chronic kidney disease, CKD, is set to become the 5th biggest cause of premature deaths globally by 2040. In Scotland, modelling by Kidney Research UK suggests that over 600,000 people, 11% of our population, may be living with some degree of kidney disease, much of it undiagnosed. According to data from the Scottish Renal Registry, 5,732 people in Scotland were receiving kidney replacement therapy at the end of 2023. Of these, 3,491 had functioning kidney transplants and 2,241 were receiving dialysis. Behind each of these numbers is a story about human suffering. One CKD patient said, "Kidney disease is insidious. It creeps into every aspect of your life. Not only that, it slowly robs you of your life." Another said, "The condition plays a huge part in your daily living. Need to work, can't work, depression, worry, anxiety, relationship issues. Life in general can be hard." Employment rates for people on dialysis are just 26%. Between 2022 and 2032, people with CKD are projected to lose 81.6 million workdays across the UK, with 11.9 million missed by their carers. The number of people on dialysis in Scotland is likely to increase significantly over the next decade, while current preemptive transplant and perineal UK dialysis rates remain below pre-pandemic levels. The direct costs of kidney disease to NHS Scotland last year was £566 million, a sum expected to reach £1 billion by 2033 without government intervention. So improving kidney care is not just clinically necessary but financially prudent. A focus on prevention, early diagnosis and greater use of home dialysis and transplantation can reduce the reliance on hospital-based care with all its associated costs. Home haemodialysis is clinically and consistently safe and effective at lower cost than in-centre dialysis, while offering patients and their families greater independence and quality of life. However, in Scotland, only 12.2% of dialysis patients receive home dialysis. This is the lowest percentage across the 4 nations and significantly lower than the UK average of 16.9%. While NHS Grampian recently expanded access to home haemodialysis across Aberdeenshire, Aberdeen and Moray, uptake elsewhere in Scotland remains low. In Glasgow, home therapy uptake is only 7.2%. A more consistent and ambitious approach is needed to expand equitable access to home dialysis. This is especially important in rural and island Scotland, where transport remains such a critical issue for patients required to travel for in-centre dialysis 3 times a week to receive life-saving treatment. Unlike other parts of the UK, there is no Scottish national framework to ensure a consistent service for transporting people to dialysis centres. That must change. 6 Scottish health boards told Kidney Care UK that access to all modes of in-centre dialysis transport they provide is needs assessed, while 6 others told them that transport is open to everyone travelling to and from in-centre dialysis. Worryingly, almost 2/3 of kidney healthcare professionals surveyed had concerns about transport arrangements their facility had in place for patients travelling to and from in-centre dialysis. I know patients, their families and those who work with them would greatly appreciate a commitment from the Minister to provide guidance and support for health boards to enable them to assist patients with vital transport needs. Presiding Officer, we must also recognise the psychosocial toll on people with kidney disease and their families. Sadly, too many people with CKD feel they are left to get on with it alone. Kidney Care UK's recent survey of adults living with kidney disease revealed that 73% of patients needing psychosocial support from their NHS kidney team don't receive it, and 69% said such needs had never been formally assessed. There's a real and pressing urgency to ensure specialist support is available to all who require it, regardless of where they live. Improving access to kidney transplantation is also critical. Transplantation offers the best outcome for many patients, yet the transplant waiting list is at its highest level ever, and transplant rates remain below pre-pandemic levels. In 2023, 265 patients received a kidney transplant. Over 480 adults remained on the waiting list as of March 2024, and this is deeply concerning. Every missed opportunity for a transplant is a chance lost for someone to live a fuller, healthier life. The transplant pathway needs to be strengthened, including better support for living donation. Presiding Officer, CKD is one of the most prevalent and serious long-term conditions in Scotland, yet it arguably remains largely absent from national health planning. The Scottish Government's own consultation on the forthcoming long-term conditions framework acknowledged that kidney disease is one of the few major conditions with no national strategy. The kidney charities represented here today and others are calling for the introduction of a national CKD framework that would include prevention and early detection, patient involvement in care, support for children and young people, effective management of chronic and acute kidney conditions, better end-of-life care. They also want to see CKD prevention and treatment to be a clinical priority, with annual testing for those most at risk, access to appropriate medications and lifestyle support to delay progression. I trust the Minister will address these asks in her reply. Before concluding, I'll highlight the Bloody Amazing Kidneys campaign by Kidney Care UK. Since its launch in October last year, around 200,000 people have completed the online kidney health checker, with around half identified of being at increased risk of CKD. The campaign has reached NHS networks, public health clinics and even the European Renal Society Congress. It's a helpful, albeit scary, reminder that you can lose up to 90% of your kidney function without realising it. Symptoms are often vague or mistaken for other conditions. I encourage everyone to find out whether they are at a lower or increased risk of developing kidney disease. Presiding Officer, I pointed out earlier that other areas of health concern steal the spotlight, so to speak, while kidney health struggles in the shadows to receive the attention patients deserve. That is changing. In May, the World Health Organization passed its first ever resolution on kidney health, recognising it as a global priority. The time for the Scottish Government to place a national and strategic focus on kidney health and ensure that every person with CKD has access to the care, support and treatment they need is now. I'm pleased that colleagues will talk of the life experience of constituents with CKD, and I look forward to hearing those stories. Thank you.
Thank you, Mr Gibson. We move to the open debate. I call first Brian Whittle, to be followed by Christine Graham. Around 4 minutes. Mr Whittle.
Thank you very much, Deputy Presiding Officer. Can I thank my colleague Kenny Gibson for bringing this debate to the Chamber, and also thank those organisations that I have engaged with fairly regularly. I met with Kidney Care UK today, in fact. I've met with Kidney Research UK. Yes, and NHS have been very helpful, as have British Heart Foundation and Obesity Action Scotland. The stats actually for chronic kidney disease are quite stark, with more than 600,000 people in Scotland living with CKD, which is over 10% of the population, and much of that, as Kenny Gibson stated, is underdiagnosed. Not be surprised to hear that poverty and health inequalities disproportionately affect people with CKD, and we hear this across many conditions. Advocacy and support teams who come up, I heard today, that are coming to Kidney Care UK for advice and grants are referring back to this. In 2023, Deputy Presiding Officer, we had 45% are sitting at stage 3 to 5, with kidney function less than 60%. And we talk about prevention, as I often do in here. CKD in Scotland is currently costing the economy of Scotland more than £500 million a year. So without significant government intervention, the suggestion is that this could rise to more than £1 billion by 2033. Again, that comes from Kidney Research UK. So the total annual economic burden of kidney disease in the UK is £7 billion, costing the NHS £6.4 billion. That's about 3.2% of the NHS budget. Of course, employment rates among people on dialysis are low, sitting at 26%. And between 2022 and 2032, CKD in the UK is projected to result in something like 8.1 million missed work days in people diagnosed with CKD, and 11.9 million missed work days by carers of people with CKD. So CKD prevalence and cost to the NHS are expected to rise significantly in the next decade. And there are a lot of comorbidities associated with CKD. And one of the things that was discussed today actually was the impact of a diagnosis of CKD would have on your mental health. And that mental health, that depression, is experienced by 1 in 3 people with CKD, worsening health outcomes and adding to the pressures on the mental health system. Through its free counselling service, Kidney Care UK hears daily from people undergoing these challenges. There is very limited support available on the NHS to patients. Obesity is linked to a higher risk of CKD, and of course, as we well know, obesity levels are at a record high in Scotland and are rising, and that's something that needs to be tackled. I do think that what we should be looking at doing, as everybody in the Chamber knows, having heard me speak of this before, is how we prevent conditions like obesity in the first place, rather than treat them, having to treat them once they occur. So that whole prevention along detection and lifestyle advice is really, really important. And it's also a major risk factor in developing of cardiovascular disease, and it can also be made worse by cardiovascular disease. We do recognise the importance of the integrated approach to comorbidic chronic disease. However, there is a significant concern that a single long-term condition framework risks oversimplifying the complexities of these long-term conditions that often have significantly different clinical pathways, specialisms and the impact on patient lives. Kidney disease in particular, as Kenny Gibson alluded to, remains largely absent from national planning in Scotland, despite being identified in the long-term conditions framework consultation as a major gap. So, in conclusion, Presiding Officer, as I get about halfway through what I wanted to say, I would like to thank Kenny Gibson. I'd like to thank the Kidney Care UK today for their briefing. But I do think that one of the things we need to look at is how we prevent in the first instance, because, as I said, the cost to the NHS and the cost to the individual is high. Deputy Presiding Officer.
Thank you. I now call Christine Graham to be followed by Jackie Bailey. Around 4 minutes.
Thank you, Deputy Presiding Officer. I thank many organisations for their briefings and for my colleague in bringing this debate and raising the profile of kidney disease. A members' debate allows parliamentarians to bring to public awareness issues which go unnoticed, and kidney disease is one of those. It also educates politicians like me. This is a disease which doesn't grab the headlines, yet it's my understanding that more people die in Scotland from kidney or kidney-related disease than from cancer, and is a long-term condition which doesn't usually have visible symptoms until at the advanced stage, and it's incurable. It should be a significant public health concern in Scotland, as this affects, as I understand, 600,000 people with CKD, chronic kidney disease, and that's according to data in a recent petition to the Scottish Parliament. There is a slow-growing understanding of the issue and calls to improve early diagnosis and treatment. Key challenges include improving access to care, supporting vulnerable patients and preventing progression to end-stage kidney disease. Now, without wishing to frighten anyone, you are more at risk if you have high blood pressure, diabetes or a history in your family of the disease. And unfortunately, currently, although there is no cure, treatment can slow or halt the progression. Apart from physical symptoms, there is a possible need for treatment such as dialysis or a transplant. And here I give notice in passing that I am sponsoring in Parliament an organ donation exhibition later this month, because despite an opt-out system, organ transplants are on the decline. CKD, an action plan for Scotland, estimates that more than 1 in 10 people here have CKD, and that of those, 45% are already in the more severe later stages. So is it not time to make this a priority? Because in this data alone, the incidence of CKD requires to be much higher up the health agenda. Now, statistics are one thing, but to bring home the impact of the disease, I shall recount Craig's story. Craig was diagnosed with IgA nephropathy, a form of chronic kidney disease, in his 20s. He's now 54. He managed his condition without intervention until the summer of 2018, when he started to feel very unwell. Tests revealed that his kidney function had dropped to a critical level, and he was immediately put onto the transplant list. Fortunately, his mother, 2 sisters, brother and partner all put themselves forward to be a potential donor, and after initial tests, his eldest sister was found to be a perfect match. He was lucky. In the interim, Craig had to go on dialysis. He opted for peritoneal and dialysis, which he could do from home and would mean less disruption in his daily life. He had to have surgery to get a tube inserted into his abdomen, which he could then hook up to a peritoneal dialysis machine at the side of his bed at home. From then, for a period of 8 months, he hooked himself up every night, and the machine used his peritoneal cavity to cleanse and filter his blood inside his body, performing the function that his kidneys could no longer do. The family grew used to the whirring, gurgling and beeping noises the machine made throughout the night. They affectionately nicknamed it George, after an inspirational transplant patient they had met. In a grim situation, a bit of humour helps. There's not yet a cure, but I hope I've given you a bit of a good note. Craig had his kidney transplant for his sister 6.5 years ago, and he's still going strong. He will be on immunosuppressants and a cocktail of other drugs for the rest of his life, but this allows him to lead a relatively normal life. He is forever grateful to his sister, and the doctors, nurses and the surgeon who took care of him throughout the process. Finally, I hope this debate progresses diagnosis and early treatment. I repeat my thanks to Kenny Gibson and to Craig for letting me tell his story, and to those attending, and I do look forward to the Government's response. Thank you.
Thank you. I now call Jackie Bailey to be followed by Emma Harper in 4 minutes. Ms Bailey.
Thank you, Presiding Officer. May I start by congratulating Kenny Gibson on securing this important debate and for the substance of his contribution this evening. Presiding Officer, we almost certainly all know somebody with kidney disease, because after all, it affects 1 in 10 Scots. But we might not be able to identify them because many of those people are undiagnosed. For every 2 people diagnosed with chronic kidney disease, according to Kidney Research UK estimates, there is a third who are struggling on, not knowing and not diagnosed. And for many people who do get a diagnosis, it often comes too late to prevent kidney failure. And behind these figures are countless tragedies and lives cut short, not to mention the misery experienced by hundreds of thousands of Scots every day. The experience of fatigue, swollen joints, nausea, breathlessness, and often many people not even knowing or guessing the cause of their symptoms. Now, kidney charities are clear. The key to tackling kidney disease is not in the A&E department when things are already possibly too late, but in the community. Prevention and early intervention rather than crisis management. So we need to see annual testing for those most at risk, such as those, as has already been mentioned, those with diabetes or high blood pressure. Conversations about lifestyle change that prevent and delay the disease. Medication that will help ease the symptoms. And technology that allows patients to receive dialysis at home rather than trekking to distant hospitals. And as Kenny Gibson rightly said, currently only 12.2% of dialysis patients in Scotland are on home therapies, the lowest across the UK. Now, I've heard from patients in rural areas. I've heard from one woman in particular on the Western Isles, forced to travel hundreds of miles for dialysis when it could be delivered at home. So these life-changing interventions can be delivered by GPs. They combine the detective work of diagnosis with a deep understanding of their local community. But I have to say, I think the Scottish Government has woefully underfunded primary care. And according to the BMA in Scotland, GPs have seen their share of the NHS budget fall from 11% to 6.2% since 2008. Now, in real terms, because of inflation, that feels like a cut of 22.8%. Targets are increasing for the number of new GPs. That's welcome, set by the government. But we know from Audit Scotland that these will not be met. Kidney Care UK is calling for a national chronic kidney disease framework that will set standards for what good quality care should look like. And I urge the Scottish Government to embrace this and agree. But it starts with ensuring that someone experiencing symptoms such as weight loss or muscle cramps can actually get an appointment at a GP, and that the GPs in turn are properly resourced to take the lead on the patient's care. If we are to make a difference, the Scottish Government must listen to kidney disease patients, listen to campaigners, invest in primary care, because not only will that improve the lives of countless Scots with chronic kidney disease, it will save our NHS millions in more costly hospital interventions. If we tackle chronic kidney disease, everyone benefits. So I urge the Scottish Government to accept the terms of Kenny Gibson's motion. Let's have a national strategy. Let's make a difference. Let's focus on tackling kidney disease. Thank you.
Thank you, Ms Bailey. And I call Emma Harper to be followed by Faisal Chowdhury. Around 4 minutes. Ms Harper.
Thank you, Presiding Officer. Can I thank Kenneth Gibson for bringing forward today's motion, which gives us all an opportunity to highlight the profound impact of chronic kidney disease on individuals, families and our National Health Service. And I too welcome visitors to the gallery and for the briefings that we've received also. In many ways, chronic kidney disease is a silent epidemic. It affects more people in Scotland than cancer. That has been mentioned already. The prevalence is about 3 to 4%, and it can have a huge impact on a person's on their ability to deal with their daily living, and also families as well. And it can hugely affect the ability to go about all their day-to-day lives, including work as well. Kenny Gibson has highlighted that really well, and I won't rehearse that further. The outlook and prognosis for those living with chronic kidney disease has improved immeasurably over the years. And today, many conditions are treatable and manageable in the long term, and the advances in transplant technology and availability over the years is incredible. I myself am a registered nurse, and I worked in California, albeit that a long time ago. I had the privilege to be part of the liver transplant team, and on many occasions took part in kidney and pancreas transplants also. So I want to put on record my thanks to everyone in the transplant and the dialysis teams and all the support services for all they do to improve the lives of their patients. The teams offer hope to many whom have previously maybe not had an option. And in NHS Dumfries and Galloway, in my region, over recent years, we've seen the expansion of dialysis services. So as well as the site at Mountain Hall Treatment Centre, which is a previous DGRI site, there are also dialysis sites at Stranraer and Kirkcudbright. This saves those needing dialysis as part of their chronic kidney disease treatment from travelling long distances to Dumfries 3 times a week. That would be quite cumbersome, I would imagine, for people who had to do that before the Stranraer and the Kirkcudbright sites opened. Home First Dialysis also offers the potential for better quality of life for those receiving treatment, and in particular for those people living in rural areas who do face the biggest practical barriers, as I've just described, to accessing that life-saving support. It won't be suitable for everyone, but we should strive to make it the default position for persons suitable, helping to support patients and reducing the pressure on secondary care facilities in our NHS. That embedding of treatment for kidney diseases in our communities is hugely welcome, and I believe is evidence of how our health service is developing in the right direction as resources allow and as the medical technology available for treatment improves all the time. Embedding also has to include primary care at the GP or community health level. We need to ensure those professionals who are usually first to see the patients presenting with symptoms but no diagnosis have the tools and training needed to make that diagnosis and get the earliest possible intervention put in place, whether that be referral to secondary care or simply identifying and managing issues at the local level. Early intervention is key. As with many other conditions, the longer problems are left untreated, the greater the potential for long-term complications and more serious medical intervention. And given the way CKD interacts with other health conditions, for example, the risk of CKD associated with high cholesterol and high blood pressure, identifying CKD at an early stage offers the potential for interventions targeted at these conditions, boosting the health outcomes not just in renal health but across the board. I don't have time today to delve into the detail of the implications of CKD at stage 1 through stage 4. That would take a whole lecture. But I do welcome the Government's ongoing work on the long-term condition strategy. I know the consultation has just recently closed, and that will be something that the work to determine and the process for moving forward is something that I'm sure the Government are working on. So I look forward to hear the Minister's response. And again, I want to thank all our dedicated professionals across our NHS and the campaign groups such as Kidney Research UK, and all to support improving prognosis for everybody who is affected. Thank you.
Thank you, Ms Harper. And I call Faisal Chowdhury to be followed by Jeremy Balfour. Around 4 minutes. Mr Chowdhury.
Thank you, Deputy Presiding Officer. I will begin by congratulating Kenneth Gibson on bringing this important issue to the Chamber today. One I have previously considered as part of the Petitions Committee when I first researched chronic kidney disease. I was surprised to find that 10% of Scotland's population are living with this condition, which would be over 90,000 people in NHS Lothian. Despite this prevalence, it is not an issue which has drawn much attention. And a third of people with CKD are not even diagnosed, according to Kidney Research UK. Chronic kidney disease, or CKD, refers to a range of conditions which affect the functioning of the kidneys. It overlaps with many other conditions like obesity, diabetes and heart disease, and can be treated through lifestyle changes like exercise. So it is right we should be looking to raise awareness. I will welcome progress that has been made on CKD in recent years, like reimbursing people for electricity cost from at-home dialysis. People in the later stages of CKD, many spend hours in hospital, 3 days a week undergoing treatment. Members will appreciate how this could upend people's lives and take them away from work, their families, or the things they enjoy. A home dialysis can lessen this burden and give people back control over their conditions. It can also free up NHS staff time and lessen the burden on health services. But only 12.5% of patients are currently treating at home. Given the benefit, I struggle to believe that is a true reflection of demand. Other countries like Sweden and Finland are looking to increase self-care to 50% and 40% respectively. We should have a similar ambition so everyone who wants at-home care can access it. But like most conditions, our focus should be on prevention and ensuring that as few people as possible get to the point where they require dialysis. That involves raising awareness of chronic kidney disease through education. It involves informing those with conditions that put them more at risk, understand how to manage their conditions, and it involves supporting primary care to reach out to those most affected communities and groups, especially ethnic minorities who are 7 times more likely to face kidney failure in their lives. Kidney Research UK's action plan for Scotland says the current approach is haphazard, with huge variation from practice to practice. The argument for a specific policy focus is a reasonable one. Chronic kidney disease doesn't have to be something that's caught when it is too late, or something which takes over your life. The upcoming long-term condition strategy is an opportunity to make that happen. Thank you.
Thank you very much. We now come to the final speaker in the open debate, Jeremy Balfour, around 4 minutes. Mr Balfour.
Thank you, Deputy Presiding Officer. And can I, like others, thank Kenny Gibson for bringing forward this motion and also to welcome people to the gallery tonight. This rightly recognises the immense impact that chronic kidney disease has on individuals, families and our NHS. I actually do have to declare an slight interest, Deputy Presiding Officer. When I was a teenager, I was going to go through some surgery and had a body scan. The body scan showed that we couldn't find any kidneys. But as Kenny Gibson pointed out, it is a secret worker, so I presume because I'm standing here tonight that I do have something happening in my body. But CKD is one of the most common and resource-intense long-term conditions in Scotland. Yet, as others have pointed out, it still remains one of the few dedicated policies that does not have a real focus. And I think we've heard tonight that this must change, because we've heard the scale of the challenge. Thousands of people across Scotland rely on dialysis every single week, while others live with a kidney transplant and many will remain at risk of progression. This demands some kind of action, because dialysis is not a treatment that one can simply fit in around ordinary life. It becomes life itself. And while our NHS does extraordinary work, and like others want to thank the doctors and nurses who do that, the system is under pressure, and those with long-term conditions are often the first to feel its strain. For those living with chronic illness, equality means access to the right treatment at the right time in the right place, whether they live in the centre of Edinburgh or on a remote island in the Highlands. Right now, we are falling short of that. Rural patients face long and exhausting journeys to access treatment. People in our most deprived communities are 60% more likely to develop chronic illness, including kidney disease, and face a life expectancy up to 25 years shorter than those in our wealthiest areas. As we've heard from other speakers, ethnic minority encounter language and culture barriers, and disabled people face hurdles with transport, accessibility and advocacy. The challenges are not abstract. They are lived day in, day out. That is why it's so important that the Scottish Government makes CKD a specific strand within its long-term conditions strategy. And I would be interested if the Minister, in her closing, can confirm that this is where the Scottish Government is heading towards and when we are likely to get it. These are not luxuries. These are necessities. We know what works. Expanding home dialysis brings greater independence, improves quality of life and reduces pressure on hospital services. Increasing organ donation rates saves lives and eases the demand as well. And prevention, as Brian Whittle says, through early screening in life-risk communities, has the power to slow progression and reduce the long-term burden on patients and the NHS alike. International examples show us what can be achieved and what we should be aiming for. For example, in Australia's Northern Territory, mobile dialysis units have transformed care for remote communities, proving that geography need not dictate outcomes. Scotland can and should be as bold. But this can't be done by government alone. It requires doctors, the third sector, organisations, industry and patients themselves. Presiding Officer, the voices must shape the services they rely on. Chronic disease is not just a medical condition. It is something that dictates how you shape your life day in, day out. We need action, and I look forward to hearing from the Minister. Thank you.
Thank you, Mr Balfour. I now call on Jenny Minter to respond to the debate. Minister, around 7 minutes, please.
Thank you, Presiding Officer. And I too would like to start by thanking Kenneth Gibson for
his
motion.
Your microphone.
My microphone. See what Mr Robertson did. I'll start again. Thank you, Presiding Officer, and I too thank Kenneth Gibson for his motion today and for the very helpful contributions from across the Chamber. We are committed to ensuring that all people living in Scotland with long-term conditions, including chronic kidney disease, CKD, are able to access the best possible care and support and benefit from healthcare services that are safe, effective and put people at the centre of their care. And I would like to thank all the organisations that are attending here tonight and the individuals who help and support those with CKD. I wish to first respond to Mr Gibson's and others' points around the long-term conditions framework. This framework recognises that while every condition is different, there are universal standards that everyone should expect, no matter what the condition they have. And I very much thank Kidney Care UK, Kidney Research UK and Kidney Research UK and Scotland's Chronic Kidney Disease Working Group for contributing to the consultation on this framework, and of course everyone else who has contributed to our public consultation. We received 371 validated responses to the consultation, and an analysis report will be published in October. We will soon announce the governance arrangements, including the role of the third sector and those with lived experience in the development of the framework's action plans. I and the Scottish Government place a huge importance on hearing from organisations representing people with long-term conditions and hearing directly from people with lived experience. This will be an important aspect of how we develop the framework and the ongoing action plans to improve services for people with long-term conditions, including CKD, especially in highlighting inequalities. I want to note the important role the third sector have played over the years in driving improvements in condition-specific strategies, and we want to make sure kidney organisations can play that role too. Importantly, this will be an opportunity for kidney organisations, as well as organisations representing other conditions, to come together and work collaboratively with the Scottish Government on improving care for people with long-term conditions. And I'm very much looking forward to meeting Kidney Care UK soon to discuss the framework, as well as attend Kidney Research UK's summit in the next few weeks. I would also like to note where our wider government policies deliver the asks of the motion, including prevention, early diagnosis, equitable access to transplantation, a home-first approach to dialysis care and improving donation rates. I think this is really important as I agree with the points that Brian Whittle and others made about the impact that this can have on people and also Scotland's economy. The Cabinet Secretary set out in the NHS Scotland Operational Improvement Plan, published on the 31st of March, that we will work to ensure people receive the right care in the right place. There are many benefits that home dialysis can offer to both NHS boards and patients, as many members have said. Last year, we implemented a Scotland-wide policy reimbursing home dialysis patients for their extra electricity costs incurred in their treatment, as Faisal Chowdhury noted. This removes the financial disincentive to making a choice for home dialysis over in-centre treatments, allowing personal choice in where and how to receive treatment, whether you are in a rural, urban or island community. I note the targets that the Nordic countries are aiming for, as mentioned by Mr Chowdhury, and I will take further note of that. I'd also like to just quickly respond to Kenneth Gibson's points made about transport, and also thank Kidney Care UK for their in-centre dialysis transport report, Left to Get On With It. We published the Transport to Health Delivery Plan in October 2024, which sets out 20 commitments across the Scottish Government and partners. And we are looking forward to hearing from a Short Life Working Group, which was created by NHS Board's Chief Executives, on the issue of transport and renal dialysis access. And as I say, once we get the outputs of that, we will be looking at it very closely. Our cardiovascular disease risk factors programme is undertaking work in this area with the aim to reduce avoidable CVD death by 20% in 20 years by improving the identification and management of high blood pressure, high cholesterol, raised blood sugars, obesity and smoking. As part of this programme, we have committed to supporting 100,000 patients with enhanced service GP appointments by March 2026 for these key risk factors, with a particular focus on supporting people living in areas of deprivation. The Scottish Government is also committed to improving outcomes for people living with diabetes. Through sustained investment, innovation and strategic policy, we're transforming diabetes care to reduce complications and support long-term health. Notably, over £42 million has been invested in the Type 2 diabetes prevention framework, supporting early intervention and remission strategies such as the Counterweight Plus programme. Through taking forward the actions in the Scottish Organ and Transplantation Donation Plan 21 to 26, the Scottish Government is committed both to increasing organ donation numbers and access to life-changing and life-saving transplantation. And I thank Christine Graham for hosting the event in Parliament in September, as we need to work to increase the numbers of organ donations that are made. Key to that is ensuring that as many people as possible have registered their decision on the organ donor register. Scotland has a good record on this in comparison to other parts of the UK, with 57.9% of the population now having recorded their decision.
Briefly, Christine Graham.
I thank the Minister very much. Do we have any idea why organ donation has fallen? Because the legislation we introduced was supposed to make it much more accessible and easier. Do we have any idea why it's not the case?
Minister.
I thank Christine Graham for her intervention. And I think what we need to recognise is that one big launch does a lot, but we need to continue that information, which is why I'm very pleased that we will be doing a Scottish Government-led publicity campaign. As Christine Graham says, we have done well, but we must do more. And that's why during this year's Organ and Tissue Donation Week in September, we will be encouraging as many more people as possible to register. This is the best way to ensure that people's wishes in respect of donation are respected. The Government is committed to supporting everyone to live longer, healthier and more fulfilling lives. We know that improvements to the health of our population have stalled and inequalities have widened in recent years, which experts attribute to the combined impacts of UK Government austerity policies, followed by Brexit and the COVID pandemic, and the cost of living crisis, and that incidence of non-communicable disease is forecast to rise if action is not taken to prevent these illnesses. And Brian Whittle regularly, if not every speech he does regarding health, talks about prevention. And I hope that having read our recently published Population Health Framework, co-authored with COSLA, which sets out our 10-year strategy to improve the wider determinants even of Scotland's health through a whole system, cross-government and cross-sector approach focused on prevention, is something that he supports. And as Jackie Bailey said, that work has to be anchored within our communities. A key priority of the framework is to improve levels of healthy weight, including ensuring a healthy diet is accessible and affordable to all. So by shifting focus from treating illness to preventing it, addressing the root cause of poor health and targeting our efforts where they are needed most, we can ensure lasting improvements for this generation and the next. And if I may, just to finish, Presiding Officer, one of the most life-affirming experiences I have had was to witness a live kidney organ transplant and meet families who have benefited from this amazing surgery. I was struck by their humbling appreciation and their wish to give back to society, to encourage and raise awareness by sharing their stories. I would also like to pay tribute, as Emma Harper did, to the fantastic teams of nurses, clinicians and scientists from our NHS who support and care for those living with CKD, and of course the third sector organisations, so many of whom are represented here. I thank Kenneth Gibson for bringing this important motion to the Chamber. Thank you.
Thank you, Minister. That concludes the debate and I close this meeting of Parliament.